Apps that we did not get to from class the other day. So we already talked about heart failure and the key points and shock, cardiomyopathies, and your valve disorders and bacterial endocarditis. So if you by chance missed that in class, I would recommend pairing up with a classmate and going through that concept map together, okay? Because that is important information to know. And we'll go through the rest of them here. And if you have any questions after listening to this, you can always reach out to me through email and ask. All right, so let's get started. Okay, so our oxygenation lecture. So our focus was on acute respiratory distress syndrome, or ARDS. So simply what that is a failure of the respiratory function due to an inflammatory process within the body. So when we think of important things that we need to know about ARDS, we definitely want to know different causes, right? Because we want to be aware of what to sort of assess for in our patients to see if they are possibly at risk for something like ARDS, because ARDS has high mortality rates. So some of the causes, thinking back from class, some of the big ones that we talked about, remember they can either be indirect causes or direct causes, meaning that the injury is directly to the lung and causes ARDS, or the injury is somewhere else within the body and all the inflammatory processes causes ARDS, okay? So going through causes, we have things like aspiration, right? That would be an injury to the lungs. So aspiration, prolonged inhalation of high concentrations of oxygen or smoke, corrosive substances, right? That's harmful to the lung tissue. Also things like a localized infection. So maybe somebody has, like a really big pneumonia that is harming the lungs and causing their inflammatory processes to kind of speed up and turn into ARDS. We also have things like shock. All right, so we've talked about that already, going over heart failure. So when someone is in shock, they're at risk for ARDS. If they've been exposed to trauma or maybe had a major surgery, okay, so post-operatively, they may be at risk for developing ARDS. Kind of speaking along the lines of trauma and a major surgery, if someone has a fracture of a large bone, so that would be like your femur or something, what would they be at risk for because of a fracture in a large long bone? Well, that would be something like a fat embolism, right? And fat embolism can also cause ARDS as well as an air embolism. Sepsis, we've talked about that in class, that sepsis is a systemic infection, causes inflammatory processes, and puts people at risk for ARDS. Okay, so I think I left off at sepsis. I had to pause it for a moment. Truthfully, my son just woke up early from his nap, so I'm going to try to finish this with minimal interruptions if possible. So please excuse me or him if you hear him in the background. I'm sorry. But let's finish getting through this. So sepsis, and then other things that can cause ARDS too would be things like massive drug ingestion or an overdose of some sort. Okay, so those are all things that we talked about while in class way back when we were learning about ARDS. So those are all causes that you should have written in your box there so you're familiar with what things can cause ARDS. Then your clinical manifestations. So these are really important to know as well, because this is how we will be able to determine if a patient is experiencing ARDS. And we want to try to recognize it early on so that patients can receive the treatment that they need. Because as we know, ARDS can quickly lead to respiratory failure and has a high mortality rate. So some clinical manifestations, we're going to see that the patient will have things like crackles when we listen to their lungs. They're going to seem like they are in respiratory distress, so they'll be having dyspnea, shortness of breath. When we check their O2 sats, they're going to be hypoxic, and as it worsens, they become very hypoxic. They also tend to have the bilateral infiltrates on the x-ray when we assess their chest x-ray. And remember, that's the whiteout of the x-ray that I talked about in class and showed the two comparisons of what a normal x-ray would look like. The lungs should be kind of like black fields. And in ARDS patients, they look white and fluffy, like they're filled with fluid. Okay. Patients will also have decreased lung compliance. That simply means that their lungs are stiff. They're not expanding very well. The alveoli are not opening as they should be. And that's all because of the extra fluid that is accumulating in the alveoli and around the alveoli due to the inflammatory process. They also will have poor alveolar perfusion, simply meaning that the good blood flow is not getting to all of the alveoli, because some of them will be collapsed and malfunctioning. They'll also sometimes have things like retractions, so intercostal retractions. Just you see that their work of breathing is very labored. All right, so generally overall, your patient looks like they're in severe respiratory distress. So what do we do for these patients? Well, sometimes we have to place advanced airways. Okay, so thinking way back to lecture, the two advanced airways are endotracheal tubes and tracheostomy tubes. So things I really want you to focus in on are what are things that the nurse will be doing for patients when they have these advanced airways. So nursing care for endotracheal tubes. Remember, we talked a lot about VAP prevention, right? Oops. Okay, so we talked a lot about VAP prevention, the ventilator-associated pneumonia, because when patients are on an endotracheal tube, they're also on mechanical ventilation. So we want to try to prevent adverse effects when patients are receiving mechanical ventilation. Okay, so we want to prevent adverse complications that can occur when someone is on mechanical ventilation. So VAP prevention, thinking back, what does that include? So that includes things like maintaining the head of bed greater than 30 degrees, right? We want to provide frequent oral care, so that's usually every 2 to 4 hours that we are performing mouth care, oral care on these patients. We also want them to be on DVT prophylaxis, right? Because they're on bed rest, so we want to try to prevent DVT formation. And we also want to put them on peptic ulcer disease prevention as well, because when the body is under that much stress, they could be at higher risk for developing gastric ulcers as well. And also with the gastric contents in the stomach, it helps to sort of keep those to a minimum so that the patient maybe has a lower risk of aspiration. Other things that we can do are sedation vacations. So remember, that's when we turn down or shut off the sedation, hopefully on a daily basis if the patient is stable enough to do so. and we assess their level of consciousness and if they are oriented. And the other thing would be performing spontaneous breathing trials. So breathing trials would be a physician order, and what we do is just simply change the mode of the ventilator and allow the patient to exercise their lungs a little bit. Okay, so it lets their lungs try to do some of the work, breathe on their own a little bit, so that way their diaphragm doesn't sort of completely forget or get too weak to ventilate the patient once this tube is ready to be removed. So those are things to help prevent ventilator-associated pneumonia. Then other things nurses will also do is listen to lung sounds frequently. Okay, we want to maintain a patent airway. So if we hear that the patient has a lot of secretions, we may need to be suctioning them frequently. Okay, so suctioning our patients as they need will help to prevent any of their secretions from building up in their endotracheal tube. Okay, so it's really important that we maintain a patent airway. Other things that we want to think of are looking at the lip line of the endotracheal tube. So the endotracheal tubes have little numbers on them, and we want to look at that each shift to make sure that the endotracheal tube has not moved. Okay, so we always want to look at the little numbers on the endotracheal tube, and that will tell us if the tube has slid out at all or if it got pushed in at all. And the importance of that is to make sure that we still have a patent airway and it's not going to harm the patient at all. Okay, so that's called the endotracheal tube lip line. Okay, other things we think about: communication. So how do we communicate with these patients? Well, we need to think of things like asking yes/no questions. Those are easy for the patient to shake their head, yes or no. We also can use things like communication boards. So they have special boards sometimes that have little pictures on them or words on them that a patient can point to if they need something. They can also write on whiteboards as well. So if they're awake enough and able to write, they can use a whiteboard or a clipboard and try to write down their question that they're trying to ask or whatever it is. So some means of communication when these patients have endotracheal tubes. Okay. Another thing is providing safety. So remember from lecture, these patients do not really like having the endotracheal tubes in place. They're uncomfortable, feels like they're breathing through a straw. So you want to be sure that these patients are not at risk for removing their endotracheal tube before it is time to. So with that, I mean that sometimes we do have to use wrist restraints on these patients to prevent them from pulling out their endotracheal tubes, because that would be a major issue if they lost their airway because they pulled out their tube. Okay, so sometimes we have to use restraints for safety. So those are general nursing care facts for endotracheal tubes. Tracheostomy tubes, it's pretty similar, right? Because it's another advanced airway, except this airway is placed surgically in the anterior neck. Okay, so things that we do here, we also want to maintain a patent airway. Okay, so things we think about to maintain a patent airway with a tracheostomy patient is very similar. So we want to listen to lung sounds. Do they sound roncorous? Do they sound coarse? Does it sound like they need to be suctioned? We don't want to let those secretions stay in the tube because they can dry up there and cause a plug. Okay, so it's important that we assess whether or not the patient needs suctioning and how frequently they need suctioning. Humidified oxygen can help as well. It'll help to loosen the secretions, so hopefully they won't build up and put the patient at risk for a plug. So humidified oxygen is oftentimes used with tracheostomy patients. Also, we want to make sure that their tracheostomy tube is secure. So we always keep the tracheostomy ties in place, right? So we make sure that it is secure, that trach tube's not going to chance falling out with activity, turning, repositioning, etc., or excessive coughing even. So we make sure trach ties are secure, and if we want to change the trach ties, we have someone else with us to ensure that we are not going to lose the tracheostomy during the trach tie change. Other things, we want to make sure that their stoma, the tracheostomy stoma around the tube, looks okay. We want to assess the mucosa and the skin, make sure it's not bleeding or looks infectious. Want to maintain a sterile dressing underneath their tracheostomy tube. And same thing here, communication is another thing with tracheostomy patients. You know, if they're receiving mechanical ventilation, they're not going to be able to talk. Sometimes tracheostomy patients are able to talk if they have a special trach that allows them to, and they can put a little passe-mur valve on the tube. But otherwise, we need to think of our communication methods again. Okay, so those are general nursing care topics for trachs. Other things, diagnostic testing, chest x-ray for these patients. Remember, they have bilateral infiltrates, meaning that they look kind of like white and fluffy, like there's a lot of fluid accumulated in the lungs. So we want to assess that and see if our treatments are working and if the infiltrates are improving. And then brain natriuretic peptide, or BNP levels, can also be used in ARDS patients. And for a normal level, we want it to be less than 100. Okay. So those are some tests that we'll be doing. Other things might be like arterial blood gases, ABGs. We want to know their acid-base status. You know, just general labs each day most often, because these patients are usually critically ill when they are in respiratory failure from ARDS. Treatments. So what can we do for these patients? So again, maintain their airway. So that may mean placing an advanced airway. If they have an endotracheal tube placed, they'll be put on mechanical ventilation to help ventilate them. And what's the big thing we want to use when someone has ARDS and they're receiving mechanical ventilation? What is the mode or the setting that we think about with ARDS patients? It's the positive end expiratory pressure, PEEP. So remember hearing about that. So PEEP is important because PEEP is a little bit of extra pressure at the end of expiration to help open up those alveoli so they don't collapse and they can be oxygenated and exchange gases. Okay, so the PEEP helps to hold alveoli open at the end of expiration in hopes that it will help with the exchange of gases. Circulatory support may be used because when you have high amounts of PEEP, it can cause increased intrathoracic pressure and decreased venous return to the heart. So when that happens, we usually end up with hypotension. So in a critically ill patient, we may be thinking of circulatory support using vasopressors sometimes. Some other things, positioning. So how do we position our ARDS patients, or what is one of the kind of first positions that come into your mind for these patients? Well, prone. Remember, we talk about prone positioning to lay them on their stomachs to allow the alveoli that are in the back lung fields to open up, okay? So prone positioning can help facilitate the opening of alveoli as well. But generally, we are placing them in all positions. So supine, right side, left side, you know, with their pillows, changing their position frequently. Usually it's every 2 hours if they are stable enough. Other things, adequate fluid volume. So we maintain IV fluids usually to maintain adequate fluid volume. Also nutritional support, so mechanically ventilated patients can receive tube feedings for nutrition support. Remember, that helps with healing, right? So it's important that we pretty much get them fed as soon as possible, and that would be by tube feeding. Okay, and sometimes low-dose corticosteroids. So those are the main things that we are usually providing to these patients as treatment for their ARDS. Some medications that you're going to see with critically ill patients who are on an advanced airway mechanical ventilation method are sedatives. So remember, sedatives are things like propofol or midazolam. Those will help to sedate the patient, keep them a little bit more calm on the mechanical ventilator. Neuromuscular blockades. Remember, these are your paralytics. Paralytics do not provide any form of sedation. They simply just paralyze the patient. So these are medications like vecuronium, rocuronium, pancuronium. Okay, so these will help to paralyze the patient in order to better ventilate the patient. Because remember, these lungs are really stiff in these patients. So if we take some of that workload away from the patient and paralyze them, the ventilator can do its job. And then analgesics, so you want the patient to be comfortable while they have an advanced airway and receive mechanical ventilation. So we give things like morphine or fentanyl to help with pain control and comfort. Your nursing interventions. So what diet will they have? I talked about this a little bit. Tube feeds, right? Generally, if it's a critically ill patient, mechanically ventilated, it's going to be tube feedings. They may be NPO, depending how sick they are, but generally thinking for nutrition, it's going to be tube feedings. Fluid intake. Like I was just saying, they could be NPO, and you want adequate fluid volume, so they probably be on IV fluids, okay? Other things for these patients, nursing intervention-wise, is making sure that they are receiving their O2, their oxygen, right? We want to ensure that they are oxygenating well, because these patients in ARDS are severely hypoxic, right? So we want to make sure that we're following ABGs to maintain adequate PaO2 levels. Patent airway is probably number one. Ensuring that their airways are open, they're patent, secretions aren't building up, they're not biting down on an endotracheal tube, blocking their airway, etc. Okay, turning and repositioning, skin care, range of motion, providing rest periods, for these patients to try to cluster their care together so you can kind of get a few tasks done at once and then give them time to rest and then come back for other things later on. Oral care, mouth care is very important. Even in a patient who has a tracheostomy, you want to ensure that they have a clean mouth and bacteria is not developing there in their mouth. And then VTE prophylaxis or DVT prophylaxis, because they're on bed rest, and communication. So those are some things that we want to think about with this patient population for nursing interventions. Desired client outcomes, I'm going to let you guys come up with those on your own. All right, so based on everything I've explained here, what would you want to see for client outcomes in these clients?
A picture.
Okay, so then talking a little bit about pneumothorax and chest tubes. So you should know the difference between the types of pneumothorax. So to run through them real quick, simple pneumothorax, it simply means that it occurs spontaneously. It occurs within a person without any trauma or anything, okay? It kind of happens on its own. And different causes would be things like a ruptured bleb, Okay, so that's like basically like a little blister on your lung in someone who has frail lung tissue. So when that bursts, then you end up with a pneumothorax on that side. And then people who have like really severe emphysema, really bad lung disease, their lung tissue is so frail that it's at high risk for sort of like tearing. Okay, so if it tears and gets a hole in it, then you're going to end up with a deflated lung. Open pneumothorax. So your open pneumothorax would be when there is an opening from the chest wall, like through the chest wall, and it punctures the lung and causes the pneumothorax or the deflation of the lung. So different causes would be, for example, like blunt traumas or penetrating traumas. So with blunt traumas, remember your ribs can break, right? Remember talking about like flail chest, if there's multiple broken ribs, etc., there's floating rib segments. Those rib segments could end up causing a pneumothorax, okay? Then penetrating, so that would be like a stab wound or a gunshot wound, something like that. Different procedures sometimes can cause open pneumothorax. So think of when people may be having a thoracentesis to remove fluid around the pleural space. So thoracentesis is when a physician, puts the needle through the chest wall to drain that fluid. And if a patient moves or they cough or take a really big deep breath, then they're at risk for that needle to pop their lung. Okay, so that would be another cause as well. Hemothorax, so that simply means that there is a blood collection. So blood collection in the pleural space. So that would most likely be caused by some sort of trauma, like a gunshot wound or stab, etc. Because think of all the great vessels that are right there in your chest cavity. So that just means that there's blood accumulation in a collapsed lung. And our tension pneumothorax. So tension pneumothorax is basically when air is coming into the chest somehow, into the chest cavity, intrapleural space, and there is a buildup of pressure and tension, okay? So when there is a tension pneumothorax, the air cannot escape from the intrathoracic cavity. And what can happen, so if you had a tension pneumothorax on the left side and that left lung was collapsed and air is somehow still being drawn into that intrapleural space, all that pressure is going to push on the heart, all the great vessels, on your trachea, and that's when you see the mediastinal shift to the unaffected side. So remember that, because tension pneumothorax are really dangerous, okay? Because it's putting way too much pressure on your heart and your great vessels, okay? So those are your different types of pneumothorax you should be familiar with. General care for a client with pneumothorax, we want to monitor their respiratory status, administer oxygen as prescribed, sit them in a high Fowler's position to promote expansion of the lungs, and just provide emotional support as well, because it's a frightening experience for a patient when they feel like they can't breathe. Okay, so that's general overview pneumothorax. So your chest tubes, so we have wet suction and dry suction, right? So big things to know are your different chambers and what they do. So talking about the wet suction first, your A chamber on the left side of the drainage system when you're looking at it is suction control. So remember, in a wet suction chest tube, we are filling this chamber with water, and we apply the suction to that chamber, and we will see constant, fairly vigorous bubbling in this chamber. And that means the suction is working properly. Okay, so we want bubbling in the wet suction control chamber. Your B chamber is your water seal. In the water seal chamber, that's that skinny little chamber with the white ball in it. And that's where we monitor for fluctuation and titling. Okay. And C chamber is also part of the water seal chamber. And that is usually filled to the 2 centimeter line with water. And that is where we look for our air leak. So we do not want to see bubbling in the water seal chamber in the C chamber. Okay, that's the little square chamber right below the B chamber. Okay, so we don't want to see bubbling there. If we see constant bubbling, then we're thinking there's an air leak somewhere in the chest tube. Chamber D is for drainage. So not every pneumothorax is going to have drainage, but things like a hemothorax would. Okay, so if they do have a hemothorax and a chest tube in place for that, we want to monitor drainage and monitor if there's excessive drainage over 70 mLs per hour. We let our physicians know. Dry suction chest tube. So A chamber, suction control, you have the little suction dial. Okay, so that's what you saw in your simulations. The dry suction chest tube drainage system has the little suction dial, and you want to make sure it is set to the prescribed amount of suction. Chamber B, same thing, water seal, that's the skinny chamber, and you look for fluctuation and titling. Chamber C, water seal again, filled to 2 centimeters. You want to look for bubbling. If there is bubbling in that C chamber, then you're concerned for air leak. And in D chamber, again, your drainage. Okay, same thing. So complications, what do we do? So if you do have an air leak in your chest tube and you see constant bubbling in the water seal chamber and the C chamber, square chamber at the bottom, you want to assess all of your connections. You want to look for the site of where this air is leaking. Okay, so you check your tubing, you check the tubing connection to the chest tube itself. Okay, you want to make sure there's no leak, everything's taped adequately and there's no holes in the tubing, etc. No titling or fluctuation. Remember, what stops the titling or fluctuation in that B chamber? Well, if the lung has re-expanded, okay, so maybe you assess the lung sounds if you don't see titling or fluctuation, because maybe their lung is re-expanded. Look for kinks in the tubing somewhere. If there's a kink in the tubing, you're not going to see fluctuation with patient inspiration and expiration. And also things like if the suction is not working properly, so check your suction. No bubbling in the suction control. You want to make sure that the water's at the prescribed level. So this is talking about your wet suction. So you want to make sure water is at the prescribed level. Generally, it's the negative 20 centimeters of water. You also want to check the suction regulator, so where your suction is up on the wall in the room, make sure that your suction's working, right? And you want to make sure that all your tubing is connected as it should be and there's no leaking anywhere. Chest tube disconnection from the drainage system. So that means the chest tube is still in the patient, but just the drainage system becomes disconnected. Okay, so what do we do here? You put that chest tube that's sticking out of the patient, you put that end in sterile water, and then you go grab a new drainage system and hook it up. And then if a chest tube is accidentally pulled out of the chest from the client, so that's completely pulled out of the chest wall, you want to quickly cover the insertion site and you tape it on 3 sides, right? So you put your sterile dressing, tape it on 3 sides, in other words called a tented dressing. And with the tented dressing, that purpose is so that air can come out, right? We want air to come out. We don't want to build up that tension. So air can come out, but it cannot get back in. All right? So that's why we tape it only on 3 sides. And then we notify the healthcare provider. Okay? So that's your general overview of pneumothorax and chest tubes, kind of your main points that you are expected to absolutely know. Okay, so then on to some metabolism, hypothyroidism. So hypothyroidism means that there is a decreased secretion of thyroid hormone. So remember, thyroid hormone refers to T3 and T4. Okay, so if there is decreased secretion of thyroid hormone, do you think T3 and T4 would be high or low? Well, they would be low, okay? T3 and T4 would be low. Your TSH on the opposite end would be high, because remember the mechanism of how the release of the hormones occurs. The anterior pituitary is what can pick up on the signals from the hypothalamus that there is not enough thyroid hormone circulating in the blood in the body. So I need more TSH to be released to go tell that thyroid, please make more hormone. So it keeps releasing the TSH and releases more in hopes that the thyroid will make more hormone. Okay? So your T3 and T4 are low and your TSH is high. Okay? So T3, T4 is low, TSH is high. Your TSH normal range, so that's right on your PowerPoints from metabolism. TSH normal range would be 0.4 to 4.2. Okay, so that's important to know, so you know whether or not that TSH level is too low or too high when you're assessing a patient with metabolism disorder of the thyroid. So some risk factors, a couple that are more common would be Hashimoto's and someone who has been treated for hyperthyroidism. Okay, remember that hyperthyroidism treatment eventually leads to hypothyroidism. Okay, because the thyroid gland is usually sort of harmed in the treatment, and then it doesn't function as well anymore. Okay, so Hashimoto's and post-hyperthyroidism. Clinical manifestations. So you have those little pictures from your PowerPoint. I would use those to sort of visualize and distinguish which symptoms go along with hypothyroidism. Right, so some of them would be intolerance to cold, so hypothyroid patients are always cold. They are fatigued, they are lethargic at times, they have weight gain over time due to the buildup of fluid in the connective tissues. They also have issues with constipation, dry skin. They may have alopecia, meaning their hair falls out, okay, brittle nails. If their hypothyroidism is severe, they could end up with cardiac disease and cardiac complications such as bradycardia and risk for dysrhythmias and a low cardiac output. Okay, so please look at your, hypothyroid picture in the PowerPoint so you can visualize your symptoms that go along with it. Myxedema coma. So this is a complication of hypothyroidism. It is a very severe form of hypothyroidism. So with myxedema coma, basically your basal metabolic rate is slowing down way too much, right? And sometimes the causes could be things like extreme exposure, prolonged exposure to extreme weather, so extreme cold. So generally, myxedema coma happens more frequently in the winter months. Also, if someone's not complying with their medication regimen and their treatment, they're at risk for myxedema coma. So your clinical manifestations of myxedema coma would be important to know because this is something that could be life-threatening. If it's not treated, the mortality rate is extremely high. The patient may not survive. So your clinical manifestations are basically very, very severe hypothyroid clinical manifestations. Okay? Their body is basically going to try to shut down. So they end up with a change in mental status. They have issues with their perfusion and their heart. So they end up with dysrhythmias, hypotension, bradycardia. They're hypothermic, okay? Their labs may be off. They end up with hyponatremia, hypoglycemia, and our main concern is for them to start on their thyroid hormone replacement again. Okay, we need to fix this before their body sort of shuts down. So those are your myxedema coma clinical manifestations. Medications for hypothyroidism. So the one that I want you to know from class is your levothyroxine. Okay, so levothyroxine is thyroid hormone replacement. Some things that you probably recall from lecture are that we take it in the morning because it can cause insomnia, so the morning is best. We take it on an empty stomach at least 30 minutes before meals. Okay, generally we also educate our clients that we don't want them to take a multivitamin or have too much calcium anytime close to the time that they've taken their levothyroxine, because it alters the absorption of the medication. Also, when they take it, full glass of water. Remember, if they only take it with a sip and it gets stuck in their esophagus, it can cause esophageal issues. So full glass of water in the morning on an empty stomach at least 30 minutes before meals. Other things we teach our clients are signs and symptoms of overdose. So if you have too much thyroid hormone circulating in your body from taking too much levothyroxine, you're going to end up with signs and symptoms of hyperthyroidism. Okay, so that would be things like palpitations, tachycardia, maybe they have some tremors. Okay, so generally are having trouble sleeping, they have insomnia. Those are some common sort of overdose symptoms. Okay, so then your nursing interventions. So diet for these patients: high protein, low calorie, small frequent meals. Our environment, you want a warm environment. Remember, these patients are intolerant to cold, so warm environment. Provide enough layers for them to wear, enough blankets if they're in the hospital, etc. Activity level, you want to provide frequent rest periods and pace their activities, simply because they get fatigued very easily. Okay, and some other things, interventions for myxedema coma. What are we going to do to help them in this life-threatening situation? You're going to support their vital signs. So when they're hypotensive and bradycardic, they may be on certain vasopressors to help increase both their heart rate and blood pressure to increase their cardiac output. You want their environment to be warm. They may need a warming blanket. Okay, they may need a warming blanket to bring up their body temperature. You want to make sure they have a patent airway. Okay, if they have a change in mental status and they're not awake enough. Okay, so maintain their patent airway if they are lethargic, and also administer their thyroid hormone replacement so they can. Sorry about the distractions. Administer thyroid hormone replacement. So we want to make sure that they are getting their thyroid hormone. That can be T3 or T4 that they receive in myxedema coma. And if they're unable to take it by mouth, they can even get it IV as well. So it depends how severe they are. So those are some important things with hypothyroidism that you should know off the top of your head. Really understand like the why behind everything. Desired client outcomes, same thing here based on everything I've explained to you in this review. Everything I've said in this review, you can kind of come up with your important client outcomes that you think would be applicable to this patient population. Then we have Cushing's syndrome. So Cushing's syndrome, remember, is when there is too much steroid hormones being secreted by the adrenal cortex. So the adrenal cortex, its job is to produce steroid hormones. But when there's too much of the steroid hormone, people may end up with this Cushing syndrome. So leading into our risk factors, chronic steroid use is a very common cause of Cushing syndrome. All right, when someone's been on chronic steroids, whether it be for immunotherapy or chronic obstructive pulmonary disease, whatever the reason is, puts them at risk for Cushing syndrome. Also, other risk factors that could be a cause would be the adrenal gland itself at the cortex being hypertrophied, hyperplasia, where it's kind of the cells are multiplying too many and it's creating more steroid hormone than it needs to. And then pituitary tumors. Pituitary tumors can also lead to Cushing's. But the main one is chronic steroid use. That's your more common cause. Clinical manifestations. So again, you have your pictures from metabolism lecture, all right? Use those if you're a visual person. It helps to sort of just see the differences between all of the metabolism disorders when you can see the pictures next to each other and how different they are. So some to just mention here, they tend to have electrolyte imbalances. So remember with Cushing's, they have high sodium levels, so they have hypernatremia, and they have low potassium levels, so hypokalemia. They also can have fluid volume excess, where they kind of hold on to fluid. So look for signs and symptoms of fluid volume excess. They also have fatty deposits that can develop. So like on the back of their neck, like at the top of their back, they have like fat deposits that can develop right there, and they call that a buffalo hump. Okay. Then also the moon face is another classic symptom. So the moon face is when their face gets kind of puffy and very round. And also they can have hypertension and increased cardiac output. And that kind of goes hand in hand with our fluid volume excess as well. So those are your clinical manifestations. But again, refer to your little picture from lecture. Treatment options. So I do not expect you to know all of the medications for this. I just want you to know what can be done for Cushing syndrome. So basically you want to treat the underlying cause. Okay, so if someone is on chronic steroid use and they develop Cushing syndrome, you want to try to reduce the dose of steroid that they are on to the minimal amount that they need to hopefully reduce their Cushing's syndrome symptoms. If it's a problem with the adrenal gland itself, they can have their adrenal gland removed. And there are also medications that can be given to inhibit the secretion of the steroid hormones. So those would be your adrenal enzyme inhibitors. But again, I don't expect you to know all of those medications. Simply just want you to know what treatments could be done for this patient. Your diagnostic testing. So normal ranges to know. So usually when we are assessing somebody's adrenal steroid hormone production, we do tests called the AM cortisol level and PM cortisol level, simply meaning a level in the morning and a level in the evening, sometimes also at night. So your AM cortisol level should really be between 5 to 23, and your PM cortisol level should be 3 to 16. So those are just your normal ranges that are good to know and also will help you in terms of preparing for NCLEX. Urine cortisol can be drawn in a 24-hour urine specimen. And really the only thing I kind of want you to know here is just the fact that when you do collect a 24-hour urine sample on a patient, you want to discard the first urine of the day. Okay, so when they get up in the morning and do their first void, you do not add that to your specimen container. Okay, you let that one go to waste, you flush it or whatever, and then the next time they void, that's the start of their 24-hour urine specimen collection. Okay, and when you are collecting the specimen all throughout the 24 hours, you need to keep that jug of urine, because they're kind of big jugs of urine. You want to keep that either refrigerated or on ice. Okay, so oftentimes, you know, when I'm working, we usually have like one of those big bath basins full of ice, and that's how we keep our 24-hour urine specimens cold while we are collecting them, and keep repleting the ice. All right, so you discard the first morning void, and then when you are collecting the specimen throughout the 24 hours, keep it cold. Electrolytes, so these are obviously important to know. Potassium level normal, 3.5 to 5. Your sodium, 135 to 145. And glucose should really be less than 110. So nursing interventions for these patients. So for instance, diet. So you want a low sodium, added potassium diet with high protein and low carbs and low calories. Okay, so with Cushing's syndrome, it's low sodium, added potassium, high protein, and low carb and low calorie. Okay. Other things that you could do for these patients, monitoring their daily weights. So remember, they can have fluid volume excess with weight gain. So you want to monitor their daily weights, monitor their I's and O's, see if they may possibly need a fluid restriction, okay? You want to also monitor for their fluid volume excess. So are they having any swelling anywhere? Are they starting to develop any pulmonary symptoms? You know, looking for your general signs and symptoms that someone is fluid overloaded. Other things that are big for Cushing's syndrome patients, fall risk, right? You want to promote their safety, ensure that they have fall precautions in place, and monitor for slow wound healing. So remember, with excessive steroid use or high steroid levels, your immune system is lower, you don't heal very fast. So you want to monitor like their skin, look for skin breakdown, because that will take them a long time to heal. So that's Cushing's in a nutshell. And again, you can put together your own desired client outcomes. Okay, and then for Addison's disease, so this is also called adrenal insufficiency. This is when the adrenal cortex is not making enough steroid hormone. Okay, so you can see it's the complete opposite of Cushing's. Excuse me, there is not enough steroid hormone. So what are our risk factors? Going back to lecture. So most commonly, it is the therapeutic use of corticosteroids. If someone's been on corticosteroids and now has been weaned off, that could actually have inhibited their adrenal cortex's ability to create its own steroid hormones, and they end up being insufficient. They do not make enough, okay, because their body's kind of relying on those corticosteroids they were on. And that's the most common cause that I want you to be aware of. But obviously, if someone has had like an adrenalectomy, they've had one of their adrenals taken out, then they're going to be at risk for insufficient steroid hormone production. Okay? Clinical manifestations. Take a peek at your pictures again. Same thing here. I'll go through them real quick here as well. So again, electrolyte imbalances. So it's the complete opposite of Cushing's. So with Addison's, you have low sodium, so hyponatremia, and then you have high potassium, which is hyperkalemia. Okay? They also tend to have GI upset like nausea, vomiting, diarrhea. Their GI system's a little more sensitive. They can have weight loss, orthostatic hypotension, generalized weakness, and also have bronze skin, that bronze hue to their skin. They sometimes call that the eternal tan. Okay, so those are your general sort of common clinical manifestations to go by. The complication that comes along with Addison's disease would be your Addisonian crisis, right? So remember, Addisonian crisis would be when there's little to no steroid hormone production. Okay, so the body cannot function without the steroid hormones. So the big clinical manifestations to watch for here would be kind of extreme signs of your Addison's disease. So you'd have really extreme fatigue, weakness. You may have very severe dehydration, and that could be linked to, nausea, vomiting, diarrhea, that's severe. So if someone's having severe fluid loss, then we need to be watching their electrolytes because they can end up with severe hyponatremia and severe hyperkalemia. They also tend to have abdominal pain along with this. Their kidney function begins to fail, so we want to watch their BUN and creatinine levels if they are in Addisonian crisis to ensure that hopefully their kidneys are not failing. And then also they can end up in shock and have what we call vascular collapse, which simply means that their cardiac output is so poor that their body is not being perfused. So they end up in a shock-like state with hypotension, the tachycardia, etc. Everything that we've talked about with shock. So those are your Addisonian crisis clinical manifestations. And the main thing that we really want to do for them is get them back on track with their steroid hormones. So administer their steroid hormones. You want to support their vital signs, their airway, etc. Okay, so that's that. Your medications. So again, I don't expect you to know all the details about these medications. I just want you to know that these are what are used in someone who has Addison's disease. So you can use hydrocortisone and fludrocortisone. So your Solu-Cortef, Florinef, all right? So just be familiar that these would be the meds that we typically see. Diagnostic testing normal ranges. So I just went through all of this with Cushing's, but just to mention it again really quick, AM cortisol levels 5 to 23. Your PM is 3 to 16. When you're collecting a 24-hour urine specimen, you discard the morning void. So get rid of that first void in the morning. You start your collection after that one. And when you are collecting throughout the 24 hours, you ensure that your jug, collection jug, is on ice or refrigerated to keep the specimen cool. Electrolytes, potassium 3.5 to 5. Sodium is 135 to 145. And your glucose should be less than 110. Nursing interventions. So your diet for these patients. So you want added salt, remember, because they're hyponatremic, so you don't often see that, but Addison's disease, you add the salt. You want low potassium diet, okay, so low potassium, and you want high protein and carb diet, okay. Fluid intake. Remember, we encourage PO fluids with this patient population. Typically, the goal would be, 3,000 milliliters or 3 liters per day of fluid intake. We also want to watch their fluid and electrolyte balance because we know that they have electrolyte abnormalities. So we need to watch that on their lab work. Also, we want to protect them from infection. Again, if they're on the steroids for their Addison's, then their immune system could be suppressed. So we watch for infection. We also want to promote safety with this patient population as well and implement fall risk precautions. And for Addisonian crisis interventions, I talked about a few of them, but we administer their steroid hormones, so basically like their IV hydrocortisone, which is the Solu-Cortef. We can give that IV. We also want to monitor their vital signs closely because of their risk for shock. We want to monitor their neurological status. We want to keep them on bed rest so that they do not expend more energy than they need to in Addisonian crisis. And we also want to administer some IV fluids, keep them hydrated, and watch their renal functions. Okay, because remember they can end up with renal insufficiency or renal failure from this. So we watch BUN and creatinine and try to administer IV fluids to maintain an adequate fluid balance. Okay, so those are your general interventions and treatments for Addisonian crisis. So this is Addison's in a nutshell again. Put together your own client outcomes based on things that I have said that'll help you to sort of apply your knowledge. Okay? All right, and then last but not least is our immunity, HIV, AIDS, okay, human immunodeficiency virus. So with HIV and AIDS, remember, HIV is a retrovirus, so that means it is on the RNA as opposed to the DNA, okay? So it's carried on the RNA, and what it ends up doing over time is really harming the patient's immune system by killing the CD4 cells, okay? So the CD4 T cells really end up damaged and they are killed by this virus. And that's why it becomes so serious, because when the HIV has killed enough of the CD4 T cells, the client then is in what we call AIDS, acquired immunodeficiency syndrome. So remember, thinking back to our lecture, there are different stages, and when your CD4 falls below 200, you are in that AIDS category, and you're at a very, very high risk for opportunistic infections. Okay, and that's usually what ends up causing the mortality, is the infections. Okay, so going through this real quick, your risk factors. So remember that your risk factors are basically kind of like your high-risk behaviors. So that would be having multiple sexual partners. Also, if people are IV drug abusers, and if they share their needles, that is a huge risk factor. There's also risk factors when mothers who are pregnant and they are HIV positive themselves. There is a risk that it could be transmitted to the unborn fetus, and also a risk during labor and delivery when delivering the baby. If they were to do it naturally, vaginally, there is a very high risk of transmission. So that's why we oftentimes try to have HIV positive mothers have C-sections. And it's also spread through the breast milk. So another risk factor would be a HIV positive mother breastfeeding her child. And then something that's not as common, but I did mention it in lecture, is that people who received like blood transfusions before 1985, 1989, they had a higher risk because the screening process was not as rigorous as it is today. So some people who would receive blood transfusions or sometimes even like organ transplants would end up with HIV because of that transmission. So speaking of transmission, so how is HIV transmitted? Well, it's through the infected body fluids, right? So that could be things like blood, seminal fluid, vaginal secretions, breast milk, amniotic fluid. So any infectious body fluid, okay? Occupational exposure transmission through like a needle stick is not very common. It's like less than 1% or something along those lines. But I will mention it just because it is potentially a mode of transmission. Okay. So diagnosing, how would we diagnose HIV and AIDS? Well, what's the first test we usually do? First test would be our ELISA test. Okay, so enzyme immunoassay tests. So these will determine if there are HIV antibodies. Okay, if it picks up on HIV antibodies and comes back positive, then what do we confirm it with? The Western blot test. Okay, so this will also be positive if there are HIV antibodies, and it will confirm that the ELISA was in fact correct with its positive result. Other things that we monitor would be like the viral load. So remember, when someone has like a higher viral load, then that's usually a poorer prognosis. So the higher the amount of HIV RNA that's circulating in the blood, the poorer the prognosis. We also can do like rapid HIV tests for diagnosing. So this would be in emergent situations, maybe during childbirth. We need to know if the mother's HIV positive because of the baby, or maybe it's someone who comes in requesting HIV testing and they are very much not likely to stick around or come back for their results. So for instance, just as an example, like a homeless population, oftentimes they are difficult to find once they leave the facility. So that can be used, rapid HIV testing, when you need to sort of know the results quickly. And then we also monitor our CD4 counts. So that's something we talk about a lot, because CD4 counts will tell us how severely their immune system has been impaired. Okay? So prevention and occupation exposure. So the biggest prevention strategy is to avoid the risky behaviors, right? We talked a lot about that in class. So that would be no sharing needles if you're an IV drug abuser. If you are reusing needles, then clean them with bleach, like the CDC recommends. Safer sexual practices. So you want to strongly recommend that they wear condoms consistently, and that they also try to stick to like one partner as opposed to multiple sexual partners. Abstinence, if they can remain abstinent, then obviously they will not be getting HIV from sexual contact. Also, if there's families who are trying to start a family, like if as a couple who's trying to start a family wants to have a baby, and maybe one of the significant others does have HIV, then that's something that needs to be discussed when trying to plan for having a family. So remember, we talked in class that if there is a couple and one of the significant others is HIV positive, the other can take something called Truvada to try to help prevent themselves from getting HIV themselves. So prevention has a lot to do with patient education, reducing the risky behaviors, and having the knowledge of what to do and what is safe in terms of like family planning if it's that sort of situation. Occupational exposure. So remember, this is like if you did have a needle stick. So your occupational exposure, if it were to occur at work, you would need to let your supervisor know. You want to try to identify the patient that it came from. But remember, maybe you may not always know the patient, unfortunately. Maybe you went to put your needle in the sharps box and there was an open sharps there and you pricked your finger with it. You have no idea whose needle that was. But you try to identify the patient. If they will consent to HIV and hepatitis testing, then we're able to go forward and get a sample from the patient and then also send the sample from the employee who was stuck. Employee health should be notified. They also should start their prophylactic HIV treatment as soon as possible. So it's within 3 days that they should start their HIV prophylaxis medication. So that's with the highly active antiretroviral treatment, right? Those are those HIV medications. So within 3 days, but as soon as 2 hours after the incident would be ideal. The big thing is get on those medications as soon as possible. And then usually the treatment is going to be for approximately a month, about 4 weeks, and they'll continue with HIV testing to keep assessing whether or not they develop HIV. And this sort of event is very stressful for someone who's been stuck. So having someone to provide some sort of emotional support to this employee will be helpful in this situation. Okay, so you should have a general sense of what to do if an employee does get stuck or get splashed in their mucosa with infected fluids, etc. You should have a general sense both for the purposes of this, class and also going forward for when you are practicing as a nurse on your own. So for common opportunistic infections, I'm not going to go through them all here, but you're condensing the content packet that we did and sort of went over in class, and then I believe I had given you sort of the top things I wanted you to know. I only mentioned a few opportunistic infections for each system. That is the same that goes for the final, okay? So just look at your condensing the content packet and focus in just on your like clinical manifestations. So for instance, if it's PCP, that's pneumonia, look at your clinical manifestations for pneumonia: shortness of breath, difficulty breathing, dyspnea, low O2 sats, maybe sputum production, etc. All right, so just your generalized, what would you look for? What are the big things to monitor with patients who have those certain opportunistic infections? So again, if it's the PCP, you're probably going to be monitoring their O2 sats, you're going to be monitoring their mental status, you're going to be monitoring their ABGs. If it's wasting syndrome, you know that they have electrolyte imbalances and fluid imbalances, you're going to be monitoring their weights, their I's and O's, their electrolytes. So just straightforward, the basics for each, okay? And that's all in your condensing the content packet. And then in terms of your treatment, so that again is your highly active antiretroviral therapy. So those are your antiretroviral medications. You have the chart in your PowerPoint that we went through together in class. And I also told you sort of the big important side effects or adverse effects that I want you to know for each. And that goes for any adverse effect that could be very harmful to the patient. So remember, like when talking about the NRTI zidovudine, zidovudine could potentially cause rhabdomyolysis. Remember talking about this in lecture? And rhabdomyolysis can cause renal failure. So what are we monitoring with a patient who is on zetavudine? Well, we're monitoring their kidney function tests, okay? So it's as simple as that. Just go through your chart that we did together in class. I gave you all the important information that you need to know, and that information applies to the final as well. So just the absolute serious adverse effects for each of the medication classes that are listed in your chart. All right, so be sure to pull that out again. If you have a question from it, maybe you missed something from that lecture, etc., feel free to email me if you have a specific question. But I did go through each of the medications and big things I want you to know for each, so that applies here as well. And then one last thing just to mention is your HIV stages. So remember, we talked a lot about the stages: stage 1, stage 2, and stage 3. So stage 1 being the primary infection. This is when your CD4 T cell count is still good. It's still greater than 500. They may have their flu-like symptoms. And this is where we kind of look at their viral set point, their viral load, to see how their prognosis is going to be. Then you have stage 2, which is your chronic HIV infection. This is where your CD4 count starts to trend down. It's between 200 to 499. They're usually asymptomatic at this time, may have some lymphadenopathy. They can live like this for several years to decades, especially if they are compliant with their treatment. Okay? And then your stage 3, I talked about that a little bit already. That's when your CD4 falls below 200, and that's when it is considered AIDS. It's the most severe phase of HIV and has the biggest risk for infection and high mortality rates. Okay? So at this point, their viral load is very high when they're in the AIDS category. It's usually very high, which then puts them at risk for infecting others. So they become very infectious when their viral load is high and their CD4 count is so low. So knowing the general information about each stage, I know we went through it in class. There are charts from the PowerPoints from that lecture. Definitely take a peek at those, because that will help you to pull everything together for what you need to know for HIV and AIDS. All right, patient outcomes goals. Again, leave that up to you. Go by what we've talked about in class, what I've talked about here, and put together your knowledge to come up with what you believe would be your patient goals for this client population. All right, if you have any other questions at all, please feel free to email me. I am available. Don't hesitate at all. All right, so hopefully this has helped you guys, and I will be talking to you soon. If I don't hear from you, I'll see you next week for the final.